So since 1999, communities of all sizes and administrations of all sizes have faced an epidemic of portions that we've never seen before. The opioid crisis has been affecting America, and it's been growing in what its damage is doing. To best understand the opioid epidemic, you have to take a look at the numbers. Last year, 64,000 people died from opioids. 64,000 people. What does that mean in terms of numbers, and how does that compare to other issues that we've had? 2017, 45,000 people died from automobile accidents. At the height of the HIV and AIDS epidemic, you had 40,000 people that died of HIV and AIDS. And from an economic impact, it's costing communities and the government over $500 billion in economic issues. Kimberly Oliveris of our host city, Austin, said yesterday, and it's one of the greatest lines that I've heard, and it made me think of this presentation today and this discussion today. And I had to write it down here so everyone I got this right. Use data as a flashlight, and use data to search for help and to find answers. In December of 2017, Department of Health and Human Services took upon that call and collected a tremendous amount of data to use that flashlight to help and find answers. We have a video that I'd like to show very quickly that kind of shows what they did during that time period. If we can roll the video, please.
5, 4, 3, 2, 1.
I'm Bruce Greenstein. I'm the Chief Technology Officer here at the Department of Health and Human Services. And behind me, you'll see the second day of the Opioid CoDesign. For 24 hours, coders from around the country have come to work on massive data sets that HHS has made available to gain insights that we didn't have before directly to save lives.
We've been up for about 36 hours straight. I didn't get a wink of sleep.
This is really our response to the opioid epidemic and wanting to do better data integration at HHS. My name is Mona Siddiqui. I'm the Chief Data Officer at HHS. We're bringing together data from across the agencies and the federal departments to make sure that data doesn't stay siloed in the places where it is right now, but gets connected to help save lives. And that is really why we're here today.
If we can't connect data, we can't have the best insights to problems we're trying to solve.
I was really excited to see that there would be some restricted data sets available. When an organization like the HHS has a call out for interdisciplinary people to come and help solve a problem, I think it's a lot more impactful.
It's a great innovative idea, and bringing that enthusiasm of the public at one place, and you would have seen like so many people around here overnight doing the coding.
And then we got an AI-driven recommendation.
So it's crunch time right now. The first 3 rounds of judging has been done. But what's about to happen is the top 9 teams will be doing demonstrations and presenting their solutions. The judges will pick the best from each of the tracks. 3 winners will be declared.
We believe that the outcomes out of this code-a-thon will have a direct impact. If we're able to save 1 life tomorrow, it'll be a huge victory. If we could save thousands in the next year, we'll really be doing our job.
U.S. Department of Health and Human Services, produced at taxpayer expense.
I love that last part. It's my favorite part. If you took anything away. So 3 people who have joined me on the stage here today have done a tremendous part in not only making that code-a-thon happen, but providing data and actually participating in the code-a-thon. Dr. Mona Siddiqui, Chief Data Officer for Department of Health and Human Services, Tyler Kleykamp, Chief Data Officer for the state of Connecticut, and Matthew Erlendson, who is, I know it's going to be a fun one here, 4th-year medical student who is studying for boards on May 24th. He is also the CEO of a group called Origami Innovations, which is a student-led organization at Yale University, and his team also won one of the tracks at the code-a-thon. So let's start with Mona. When most people think opioids, they don't think data. What drove the approach for HHS to use data to address the opioids crisis?
Well, so our office really has been the home of using data technology to move strategy at the department. And when the call to action really came across the department for everybody to do their part in addressing the opioid epidemic, we said, you know, yes, we might not be the domain experts, but we know one thing for sure, which is that data should be at the center of sourcing solutions to some of the most complex problems. And we also know a few things, that we might not completely understand the scope of the problem, much less being able to figure out how you target solutions appropriately. So can and should data be at the center of that conversation? Absolutely. And our strategy really was to bring data together from across the different the different agencies within HHS. So CMS, AHRQ, CDC, many different parts where the data continue to be siloed, where we are great at using data for primary reporting purpose, but not for bringing it together in service of really addressing a big problem like this. So we were grateful to have you guys as partners in really being able to do that, bringing together 70 data sets from not just within HHS, but from states and from other federal departments like Department of Justice. And I really do think it was one of the most comprehensive data sources that we were able to bring together for this one problem.
When you take a look at 71 data sources from a number of different places, what are the challenges that you found when aggregating this type of data? It's spread out all over the place. What were some of the things that you found were the hardest to deal with?
So, you know, there are technical issues in bringing the data together, but really the biggest is a cultural shift in how we think about data. People often think of data as their data, and that's why it sort of continues to be siloed. So to change the mentality from that, which is we're going to use this data for the explicit reason why we collected it, and to have people think beyond that, to how can we start to connect data in ways that we maybe haven't even imagined, and try to think of solutions from this data. So how can we actually put this data to work in ways that we haven't put it to work before? I think that is a huge culture shift, and it's going to take a long time for that to completely transform the way the department operates. But that really was one of my personal reasons for doing the code-a-thon as well, was because I think it's a great visual for the department to start to see how its data can be leveraged. And I think we did that. There are other issues too, right? For instance, getting data at the individual level versus the county level versus the state level. We tried to be consistent, but honestly, it was very difficult. And at the end, I was just grateful to get the data and try to get it in as granular of a form as possible so we could do the linkages across. I think in some cases we were successful, in others we made some progress and have a lot more to make.
One of the things that really stood out to me, and as part of this code-a-thon, was there was a symposium. We've reproduced the code-a-thon at University of Louisiana Lafayette just a few weeks ago. The symposium has always been something that's been fascinating to me. You've brought in a number of people with expertise in a number of areas. Victims, you've brought in parents of people who have died, first responders. How do you think that has affected how people build the apps and how people think about the opioid data?
Yeah, so you have to provide the context, and for our code-a-thon, if you go back and look at the numbers, about 60% of the folks who showed up, and we had about 250 people come from across the country, 60% identified themselves as not from the healthcare space. So when you think about that, first of all, that's great that so many people are coming because they feel this call to action. But it's also our responsibility to provide the context for what it is that we're talking about. So we had Secretary Sutters from the state of Massachusetts who came and presented about really sort of the state level perspective and the numbers that they're taking a look at and how that's impacting some of the solutions that they're able to implement. We had the mother of a mother who's lost her daughter and who had lost her daughter 7 months before she came to the symposium come and present about just the system and the way that her daughter moved through the system. I think those things are really powerful, both from the top down as well as from really on the ground, what are parents suffering with, what are these individuals who are addicted suffering from. And providing that context for the data is essential in order to form solutions that can be really applicable.
Great. Tyler, the state of Connecticut has done a fabulous job with opioids information. If anybody out there hasn't seen the state of Connecticut's opioid information, I encourage you to take a look at it. It's one of the most complete data sets that we've seen out there. And when we go to these types of code-a-thons, that's one of the data sets that people always talk about is, you know, Connecticut has such great data. Can you kind of walk me through from the beginning to where you are now through that data journey of getting the information out to Socrata?
Sure. So I think probably like most governments, either state or local, a few years ago, a group of us got together and sort of led by our governor's office, recognized that we have a problem and started thinking about some strategies in terms of how to address the opioid epidemic, as well as sort of the addiction epidemic overall. And this was actually one of the more sort of fascinating experiences for me in doing this job for about 4 years. It was actually the most painless release of data that I've ever sort of experienced, and yet it's one of the most unique data sets that we have. And so one of the first things, one of the first data sets we realized we could make accessible to people were overdose-related deaths at the individual level. And when I heard this, I was a little sort of surprised that somebody would be so willing to make this data available. And then two, that it would be at the individual level. I think anybody who's dealt with data at a state level tends to see it come through at a county level or a town level, and that's usually our experience in Connecticut. And so when I received this data set, I was sort of blown away. And so it actually had individual names in it, addresses, things like that. And so this was actually the first time in my career that I actually said, you know what, I think we're actually making too much data available here. So you heard Ben Wellington talk about this a little bit yesterday. And I got a little pushback actually when our medical examiner said, well, this is valuable information. We're dealing with a public health crisis here. We should be making this data available. Not that you can't access it. But it's been a pretty remarkable experience for me to sort of see some of the agencies really come forward and recognize that they have something to contribute in a way that maybe they hadn't seen previously. And so we've made some other data sets available. One of the more sort of, I don't know, unique data sets that we make available as well are pharmacies that dispense naloxone. And what was interesting about that is that originally we didn't actually have this data. And it started with an individual literally calling pharmacies in the state and asking them whether or not they dispense naloxone. And they entered that data into a form. It was actually a Socrata form. And that went directly onto the site. Over time, what we realized is our Department of Consumer Protection licenses pharmacies, and we have a licensing system where they go in and update their information. So now, as pharmacies go in and update their information, we just ask them, and it's automated and updated on a nightly basis. We've done the same thing with prescription drug drop boxes. One of the strategies that we had with this was, effectively, we know we have a problem in Connecticut. Last year, we exceeded 1,000 overdose-related deaths for a state of about 3.5 million people. And so we didn't want to just make data available that would tell us that we have a problem, because we already know that. We know that it's going to continue in that direction for some time, but we wanted to make data available that could help us address the problem. We heard a lot of information from people in the community that access to treatment, resources, naloxone, these things were hard to come by. So we were able to make data available in terms of where to get substance abuse treatment, licensed counselors, the programs, those sorts of things, so that we could better connect people with resources that are available to them as well. So that was a big sort of focus for us, and we wanted to make sure that obviously that information was timely. So these things are all automated, made available on sort of a nightly basis to the extent that we can do that, and so that was a big focus for us.
You'd mentioned the drop boxes, and that was one of the biggest things that people had said to us during the code-a-thon is, wow, this is amazing information. And some of the insights that were drawn from that data set when you look at the overdoses, I think it was, you know, the farther away you are from a drop box, the more likelihood you are to abuse opioids. How does this type of insight affect policy and how you move forward in releasing data, and from a program standpoint, how you actually work with your programs?
Well, so the thing is every little bit of information that you derive from releasing data helps us from a policy perspective. So this is a relatively simple concept, right? That if we don't have enough locations to dispose of drugs, you would attempt to deploy more of them. And so these are some of the things that we wouldn't ordinarily be able to come by on our own, because many of us are sort of heads down, you know, trying to do a variety of other things. You know, another interesting thing that we found internally through access to this data was that 50% of the individuals who died as a result of an overdose were formerly incarcerated, or at least involved in the prison system in Connecticut in some way. So that's really powerful information to know for us from a policy perspective, because we can say, okay, when we reintroduce people back into the community, are we doing enough to support them when, you know, from substance abuse treatment or whatever it may be? And these aren't, you know, that's sort of a challenging thing to deal with, but knowing that obviously helps us moving forward.
Great. Matthew, one of the things that amazed me was I never knew about Origami Innovations and the drive that they make towards solving these types of issues. Can you talk to me about what drove Origami Innovations and your team to this type of event for the code-a-thon with the opioids, and what were some of the things that you've learned from it?
Yeah, definitely. So, you know, I think one of the things that we focus a lot on at Origami Innovations is this idea of sort of inclusive, human-centered design. So we actually heard about this event at HHS, and kind of what Mona was talking about with the symposium about bringing in so many different stakeholders to the table to focus around this issue. You have a lot of technical people from different industries coming from so many different backgrounds, but actually being able to talk to first responders, being able to talk to family members who had lost family members to the opioid crisis, being able to talk to patients and legitimate users of opioids, being able to talk to providers who dispense these opioid pain medications. That was a huge sort of impetus for us to actually participate in this event. When we decided we were going to try to get involved with the symposium, we wanted to, at the very last minute, decided to see if we could put together a team and kind of reached out into our network to apply for the actual code-a-thon event, and we were accepted. And I think that I would be very surprised if everyone in this room hadn't been touched in some capacity by the opioid crisis. Personally, I've had family experience with this, but also kind of a research background in it as well. So, from a personal perspective, there was a lot of involvement, a lot of interest and involvement on my end, but also, what HHS was doing was just so much in alignment with kind of what we were trying to accomplish as well.
One of the things that I know has been a challenge for a number of code-a-thons and a number of people that are doing research on this topic is getting data in an open and usable format. How does that affect the solutions that you're able to build and the innovation that can come if it's in a closed format, and how have you worked with those situations before?
Yeah, I think that one of the things that I think about is sort of lowering that barrier to entry for, whether it's industry or academics or startups, and I think that HHS and Socrata has done a really incredible job in that capacity. When we were actually driving down to DC for the event, I was kind of just talking with some of our team members and rambling off ideas, you know, one of the things that we realized when we kind of got to the event was, you know, it was somewhat difficult to create these narratives between data sets. And, you know, in healthcare, there's, you know, you have to make sure that you share these in a way that's very secure. But at the same time, you know, we had a lot of ideas surrounding, you know, how can we bring in information from, you know, the judicial system? How can we bring in information from the education system and start connecting all these things? And we also wanted to make sure that, you know, we were thoughtful about the idea that, you know, the opioid crisis is likely very different in Connecticut than it is, say, in Arizona. You know, we were lucky to stumble upon the accidental drug overdose data set from Connecticut from 2012 to 2016. It had a lot of the information that we needed, but most importantly, it was in a format that was usable. You know, one of the things that we were thinking about was, you know, what does location mean when you collect this data, and how is that standardized? And, you know, states, you know, towns and cities are going to have different ideas about what's important within that data. So, you know, if you think about, okay, you have location as a city, you have it as an actual, you know, GPS coordinate, you have it as an address. These are some of the things we need to start thinking about in terms of how we standardize and actually collect this data. You know, actually, I think Tyler and I had a conversation earlier about this idea of kind of like quality of data too, and it's almost sort of like the idea of like the Toyota method, where, you know, you can really start have anyone kind of stop the process along the way, and thinking about, you know, who are the individuals who are actually collecting this data, and what are their thoughts about what the quality of the specific data actually is. So we do think about adding a lot of context, but you know, the ability of Socrata to kind of start collating all this data is just an incredible first step. It made it very easy for us to kind of start digging in and coming up with solutions.
So one of the things that I would love for you to tell the audience about is talk about the app that was created by your group. And, you know, your group won one of the tracks for the code-a-thon. Tell us a little bit about the application.
Yeah, so you know, the whole goal around the event from our perspective was to say, and from HHS's perspective was to say, you know, how can we create some sort of actionable insight that that has the potential to save lives? So that was kind of what we were focused on. And again, I was saying that we came in with so many different ideas, but we also wanted to create something that we felt like would actually have the capacity to save a life. And, you know, talking about sort of design thinking and this inclusive model of ideation, we actually ended up getting our idea from Joe Riff, who's a first responder and responsible user of opioid pain medication. He's an amputee. And we were talking to him a little bit about, you know, how they kind of respond to opioid overdoses from the first responder level. He was saying, you know, we've you know, over the years, we've developed this somewhat intuitive approach where we call other counties in the area, and we kind of ask them, you know, in this analog way, you know, oh, are you having any problems in your areas? Are you seeing any increases in opioid overdose or mortality? And over time, they've developed kind of this intuitive map. And we just asked him, you know, said, if we could make something that could give you those insights in a much more granular fashion in real time, would that be something useful? He said, yeah, so let's build it. And we actually found the tools that we needed in the Connecticut data set. So basically what we did was we created a platform that can utilize real-time data come in to help us make predictions about where and when opioid overdoses and increases in mortality are going to occur in the state of Connecticut before they actually occur. So one of the stories that we actually thought of was how in 2016 New Haven ran out of immediately available Narcan. You have things like heroin overdoses where you don't require nearly as much reversal agent as, say, some of the more synthetic opioids like fentanyl, where you can keep pushing and pushing and pushing over time and really sort of deplete your supplies. So we felt that you know, if you can make accurate predictions about where and when these are going to occur before they happen, that you can sort of better allocate resources. You know, one of the first things that comes to mind is obviously naloxone, this reversal agent, but also better deploying community resources. You know, each community sort of has their own set of resources they can better deploy to, you know, get people on the street and to kind of help better facilitate saving lives.
And I think we have a video, if my memory is correct. We have a video of the application. If we could go ahead and play that really quickly.
With Telesphora, we want to empower communities, give them an analytical tool that helps their data-driven decision-making. We designed a geospatial visual tool based on time-variant Poisson distribution. The machine learning model was trained on the 2012-2016 accidental drug-related deaths of Connecticut and is able to predict the future heroin or fentanyl outbreaks in each county based on its surrounding counties. This outbreak prediction can help small counties with limited data to better contain opioid outbreaks and allocate resources like naloxone, a medication designed to rapidly reverse opioid overdose. We were successfully able to predict the actual number of overdoses in each Connecticut county over 83% of the time, within a 90% confidence interval. Notably, the algorithm was better at predicting spikes in demand, points which were significantly above the mean. The clinical impact is empowering local communities to prevent over 96% of opioid-related overdose deaths. Data-driven decision-making doesn't require big data. Real-time data analysis and outbreak prediction save lives. Let's co-create a solution that works for your community.
Wow, 83% accuracy.
And one of the things I just want to mention about this is that this was just with open data from Connecticut. So one of the things is that we can improve the efficacy of this model substantially by getting more data. So the more data that we're able to funnel into this model, the more accurate it can become. So one of the things that we really do think about is access to real-time data and how can we start partnering with governments and stakeholders to get better access to that real-time data, funnel this into the model, get access to even more data sets, and deploy it in communities.
So Tyler, when you look at 83% accuracy and being able to predict where these outbreaks are going to happen, from a resources standpoint, from a budgeting standpoint, how does this help the state of Connecticut to be able to deploy those resources to react?
Well, so the state involvement in this, I think, is maybe not as critical as what's going on locally, right? So I think that there's an opportunity to really help cities and local governments, EMS providers, groups like those that are the first responders to be better equipped to understand a problem before it might occur. But I will say at the state level, we are looking at mechanisms to prioritize or support the distribution of naloxone. We are looking at opportunities or better ways to support addiction treatment, and we fund those types of things. So this idea that we can start to understand a problem before it's going to happen and formulate a response, so when that report of a spike in overdose-related deaths happens in the media, the idea that we can start to mobilize now and hopefully prevent these sort of downstream problems is so incredibly valuable, I think, to everybody, both at the state and local level.
So one of the last questions that I actually have two more questions. I'd like each of you to kind of give me your thoughts on this. As you've gone through this process, what is the biggest takeaway that you've learned from this entire process?
You want me to start?
Yep.
I think there are just so many takeaways. I think it's incredible what can happen when the federal government says, come and help us, right? This is really one of the worst public health crises that we have ever seen. And we are saying here that we don't know how to address it. when we open the doors to HHS and say, come and use HHS data to help us address this problem. And you get such a coalition of wonderful public-private partnerships. That's how I really see the code-a-thon as a true expression of that partnership in real time using data, that you can actually come up with solutions that we on our own would not be able to. And data is really the conduit through which we're communicating and through which we're actually able to coalesce to, in a very meaningful and tangible way, come up with solutions. So for me, that is a huge stride for the department to open its doors in this way. Really, for the first time, we stayed open really for 36 hours overnight and had people at the department that for them it was the first time that they interacted with the federal government in any capacity. And again, it was through the drive to use data. I think that is the start of thinking about how do we collaborate in a different way. There are ways that we traditionally work with partners outside, whether it's contract vehicles or others. And then there's this way through data, which is saying, okay, here's the data. We are the stewards of it, but we are not the owners of it. Come from the academics and industry, and let's work together to start to figure out if we're even thinking about the problem in the right way. And so again, for me, this was an amazing visual to see how the department started to change the way it was thinking. We had our acting secretary at that time who stopped by 4 or 5 times completely unannounced because he was really fascinated by what was happening and how HHS data was getting used. And we forget that for people who are not embedded in the data space every day, you don't really know what people are talking about when you say data and a code-a-thon. And so it was great for both from the top leadership level from HHS as well as from agencies and folks running programs to come and hang out with the teams that were coding to see how the data that they have seen for a long time as their data was actually getting used to address a real problem in real time, and that they could provide input and feedback as those solutions were getting developed. So I think for me that was an incredible takeaway that here's another way for us to be able to communicate and work with people outside the department.
Great. Tyler?
For me, it was, this is why we do this, right? This is why we're making data available, whether it's related to opioids or transportation or whatever. And it's so that we can partner with the federal government, we can partner with entrepreneurs, the public. I didn't know Matt before this, okay? He lives 45 minutes from me. Did all this work using our data without us ever having had a conversation, and solved a problem that's incredibly challenging for us to deal with in government. And so I take this story and I go back to my agencies and say, this is why we're doing this, right? This is why this is important. And we can release data that may seem sensitive to some of you, but it's not. It's public information, even if there are some things we felt we needed to redact. But there's so much value in it that you didn't maybe necessarily think of when you embarked to collect it, right? And not only that, it's not only valuable to us in Connecticut, we're seeing this data used by people all across the country because we're the only ones making it available at this level of detail on a statewide basis. And so I think this idea, as Matt said, that more of you can contribute data to help us solve this challenge is only going to refine the products and the insights and the things that we gain. So that for me was, it really proves the point of why we're doing this every day.
And Matt, I know you got to spend 36 hours in a federal building. You got to spend the night at the building. Something that I know we've all wondered about. I know that we'll have a separate session on the takeaway from that. But what do you think about this from your side? What is that takeaway that most impacted you?
Yeah, I think this idea of partnership is really important. That's already been mentioned, and partnering with federal government, partnering with state and local governments, partnering with industry. Industry has a lot of experience, but also partnering with individuals within the healthcare system, providers and patients, and really getting that on-the-ground perspective to start sort of translating some of the things that we can do with technology and data and implementing them into a very, very, very complex system. So I think the biggest takeaway for me is that I love the opportunity to be able to be a part of something like this and to contribute to something like this. I think it's an incredible step for government and industry, entrepreneurs and academics to come together to work on some of these important issues and to sort of reduce the barrier to creating these partnerships and opportunities.
I'll stay with you for the last question that I'll ask each of you. Call to action from the audience. What is your call to action for everybody here today?
Yeah, so I think the call to action from our end is to say, let's be very thoughtful about how we start standardizing and creating opportunities for other individuals to work with this data. Think about how we think about the level of quality in the data as well. I do a lot of thinking about improving access to real-time data. So in healthcare, that's something that we sort of struggle with, and I know Connecticut kind of has a bill going through right now to better help the public health department get access to real-time data, and then to also encourage people to really bring in these partnerships into their thought process. So, if you're not talking to patients and if you're not talking to providers, you're not talking to the people at the ground level, it's going to be much harder to create those actionable insights, just bringing in maybe the technology or the data perspective. So really sort of building out those collaborative partnerships would be important.
Tyler?
So I think we're just starting to sort of scratch the surface of what data exists and where it exists and how it can help address the problem. And so one, I would say, if you work in a state or local government, we've sort of taken the step, right? We've taken the risk of making this data available, and we haven't gotten in trouble. Nobody's sued us, right? It's public information, and so don't take no for an answer because it can help. But if you are getting pushback on that same type of data that we're releasing, there's all sorts of other data sets that you can make available to share with other people to find solutions. So go find one, right? Go back and say, is it Dropboxes? Is it where to get help? Whatever it is, go find one and make it available. And that will start a process within your own sort of government that hopefully will make more and more data available.
And Mona?
Yeah, I think the one thing that I learned, and would be my call to action, is don't take no for an answer. And no is just the start of the conversation. And then you have to work towards yes, if, and what is it that you need to do to move from the no to yes, if. And I'll say, we did not think that there was some data I absolutely did not think we were going to be able to get from HHS. And those conversations, for the first 45 minutes would be no, no, no. And then for the last 15 minutes, you kind of wear them down because they run out of reasons to say no. And then you start to say, okay, here's what you could do. And take those incremental steps, because they really are the method by which you get to your ultimate goal, which is to get more data available that really can help both states and the federal government to really start to, in more real time, use data to address some of the complex problems.
Mona, Tyler, Matt, thank you so much for everything that you're doing to help fight this crisis. And please get information out there to help save lives, everybody. Thank you very much.
Thank you.